Okay, right. Hello, good evening from the King's Fund for another of our series of health chats. I've got a spectacular guest for us tonight, but before I do that, I just want to take a moment to remind you about these. You want to give me one of those things? Between the 13th and the 17th of November, it's Change Day, but it's been converted into Change Week. I'll bring that a bit closer to the screen. Can you see? How am I doing?
Yep, perfect.
Is that okay? Fine. These are pledge cards. You can download them from the FAB website, and they're all over Twitter and what have you. So please don't forget to pledge either for your organisation or individual. So enough of that, I think. So we'll just press on. Really interesting topic, I think, tonight, mental health. I know that from my years in the service, is Eve Richardson here? I know. I think she should be here. And Eve and I used to work together. She was the chief executive. I was the chairman. And Eden, of course, is here, who worked with us in some capacity to her entire satisfaction. But she was great. And what I learned was, having been involved with secondary care, really as a health authority vice chairman and later a chairman, that it isn't until you get involved in mental health services that you realise what the health service is really about. It is really, really difficult, and I know of no one who's mastered it better than our guest tonight. So will you please give a very warm welcome to... Oh no, I forgot the sponsors again.
Talk to this lady after, she'll make you better.
Of course, these fabulous events wouldn't be possible without. I've done this twice. I've got to tell people I have this twice. I've forgotten to mention. Twice in the whole of my career, I've forgotten to mention the sponsors twice, and it has to be the same sponsor. So let's have a word from our sponsor, who is a thoroughly delightful chap. There's nothing like a good sponsor, and he's nothing like a good sponsor. Ladies and gentlemen, from IMS Maxims, we're very lucky to have with us, walking amongst us as though we are ordinary people tonight. It's Dr. Michael.
What do you say? It's a pleasure to suffer the ritual abuse.
Michael, I'm just going to tell you, your head's cut off. Could you move over where? Because after that build-up, they want to see you, Michael. So would you go over there? No, please, over there, Michael. You're looking it perfect. Perfect. We can see you now. Yes.
Can you see him all right?
Yes.
It's important the sponsor gets high visibility on that. Oh, sorry.
Yeah. Well, he said, walking amongst you as if he were deity. Well, there you see. So, seriously, it's a pleasure to welcome you all again. We really love doing these events, as you can tell from the nonsense we get. But we have a super guest, a special guest in Claire. As an organisation, we have an interest in mental health and are committed to making sure that we have solutions that work, that the clinicians want rather than the managers want, if I dare say that out loud. And we know that she's a superb speaker, engages the heart, gets everyone to follow her wonderfully. And without more ado, please welcome Claire.
Thank you very much. Ladies and gentlemen, Dame, soon to be, Claire Murdoch. Okay, I'm just, if you might see me, okay, I'm just going to clip on another microphone. Because we want to improve the sound a little bit for the folks who are watching us on...
Same place?
No, that's it. Okay. The folks who are watching us on Periscope. Let me just get something. Right, you only had one job. Okay, leave it to me. I'll do it. It's a kind of man thing, isn't it? Right, now don't stand up because you'll electrocute. Okay, have we got sound? Yeah. Okay. It's a bit late to find we haven't, so don't worry. Okay, fine. We're good to go, yeah? Good. Well.
Hello. Good evening.
God, was it worth it? Claire, thank you very much for coming. Mental health sort of in the news, isn't it, everywhere today? I see today the Jim Reaper is talking about the money, and I think they started the query today whether there'll be enough staff to be able to carry out the mental health in the community.
Yeah.
You've seen that? Have you seen the HSJ today? Yeah.
Yeah, I haven't seen the HSJ today. Shock horror, because I do catch up with it most days.
Yeah.
I'm having a very busy day today, so I haven't seen that one.
Yeah.
But are you wanting to talk about workforce?
Well, I mean, it seems to me that's one of the key issues.
Yeah.
Isn't it, workforce?
Yeah, it is.
Where are you going? Well, I mean, let's cut to the quick. Where are you going to find 10,000 people by 2020?
Well, I think we're going to find them through a number of routes. And can I just say, I think the first issue with mental health is to stop saying how awful and tough it is, how morale has never been lower. You know, the media is suddenly full of bad news mental health stories. And as I go about the place or go about my trust, I can tell you, and I was on induction with 170 new staff today, 2 sessions. Most people working in mental health are far from down and out. There's huge innovation. No, you didn't, but you asked where will we find the people from, and I suppose what I'm saying is the first thing we have to do is showcase, which is why thank you so much for asking me to be here tonight.
Well,
is to start
finished yet.
I know. I'm grateful at the moment. But you know, I think the first thing we have to do is start showcasing some of the really great work that is going on and make it a place that people want to be, make it a set of career choices that youngsters want to follow. I think we have to look at engaging and keeping the staff we've got. And when you actually break the numbers down, say of 10,000 staff over 3 or 4 years, divided by the entire country, 44 STPs, you suddenly get to a set of numbers that maybe says, well, each STP has to find 250, 300 staff. If it's, in fact, it's slightly less if you're going in at the 10,000 mark. I believe that's possible. I think on my induction today, my trust induction today, we had peer support workers joining the workforce, working in a range of settings. We had some apprentices, we had admin apprentices, we had clinical apprentices, amazing, a totally different set of workforce coming in.
Only just de-skilling the workforce?
No, because it's not instead of qualified staff. I had about 24 brand new qualified nurses on induction today as well. So I think that it's really, really important to take a rich and textured view of what a good, competent work. Rich and
textured view.
What a good, competent work.
Phrase. I like that. I might steal
that.
that.
It is.
So
for example, peer support workers, people with lived experience, whether that's in HIV, learning disability. People. Might be younger people with lived experience, but giving jobs to people with lived experience who have got the competencies, the skills, training them, supporting them, is a really rich and untapped element of the workforce.
Are you moving away from a therapeutic model into what? An unskilled model?
No, definitely not. I mean, the plan that was published a few weeks ago...
There's a clinical model, there's a medical model, therapeutic model, and a what?
So I think the model for mental health is absolutely about prevention, expert patients, using carers more, looking at social care, so making sure that you value...
Hang on, everybody says, you know, oh, we're going to go upstream and stop people getting sick. Nobody does it.
And
how are you going to do it?
I think it is possible.
Well, how?
I think the STPs give us an opportunity.
STPs are a bunch of the bewildered with no budget trying to do enormous amount of heavy lifting on top of the day job. What are they going to do?
So I don't think that thinking in an integrated way is new for mental health. So I have been in mental health for 33 years, and back in the early 90s, and I can tell some people in this room will be old enough to remember this, we thought it would be a good idea, no offence. I need some friends here.
I've already pissed off the sponsors, don't have another go.
So no, but I can, you know, so back in the 90s we thought it would be a good idea to bring social care and mental health closer together, so we integrated
it. It used to be the Department of Health and Social Services.
You will remember that. Yeah. And now, of course, we've got much smarter.
We've got this great idea called health and social care.
Yeah, and now,
when are you going to do it? You've been talking about it for ages.
Well, I think lots of parts of the country do. I think there are some great third sector organisations that do. I think the independent sector plays a great role, and in areas of the country where it's working well, and you know, ever since I've worked in the NHS, there's a variable landscape for how things are working. But I think the areas of the country that do it well already do operate some really Lambeth and the Mental Health Alliance in Lambeth, Tees Escombe Weir, who are looking at new care models and preventative work. Where have you been that does it well?
I was at Rob Webster's Trust.
Thank you.
Just recently. I have to say, he surprised me. As a leader, he's really surprised me, because he was running the Confed at the time, and you know, they're pretty much finished now. They're run by two old geezers, and nobody wants to join, and you've got Hopkins has eaten their lunch and everybody joins professionals now. So, I mean, they're pretty much finished. So he bailed out at the right time, and he went to take on a trust.
He did.
Not an ordinary trust, like offender services, and you know, really, really difficult. And he's doing a storming job. He really is. And I went somewhere else. Hang on, Blonde. Where did I go? Was it Hull?
You did go to Hull.
Was it Navigo?
Yeah.
Yeah. Is that where they've got the garden centre?
Yeah. You did go there.
Have you been?
I haven't, but I've followed you. I will get there. I'm all over the country. I will go to Hull.
It's no good saying Roy Lilley's been. It's all right. Look, let me tell you.
I will go there.
Roy Lilley's been. They closed it. Look, I need to tell you about this, right?
Yeah.
Because I think all this is about merging health and social care. It's never going to happen. Politics are too difficult. Entitlements are too difficult. Where you've got people that have got. You know, some people have free services and some people don't, entitlements and all of that. It isn't going to happen. The politics of it won't let it happen. Forget it. Right. But what I have seen when I went to, was it Navigo? I tell you what, I can't tell you how good that place is.
Yeah.
I sat down in front of the screen and I watched the cursor blinking. I thought, how the hell am I going to write about this? Yeah. They were superb. Now what they've done is, they've reinvented social care. They bought a garden centre, a garden centre. Now I'm quite sure that we're going to find this is ultra vires in the end, because I'm not going to know where the money's come from. It's certainly not healthcare money that buys a garden centre, right? But it's a proper commercial business. Yeah. And so they've got people working in the garden centre. Now when you think, no, it's not just, you know, a few people doing a bit of potting and all that. No, it's run by service users. Yeah. There's a cafeteria there, fantastic thing. The kitchen is run. So the whole business. On top of that, they then decided they needed to maintain the place. So they started a building company. Then they said, well, if we're going to do building, we might as well do carpets. So now they're running a carpet cleaning business. They've got this great sprawling empire that actually employs people and gets them back on their feet, back into work. Because what we know is people need somewhere to live that's safe, a job and someone to love. Yeah. And they do those three things. Yeah. Forget social services, they never do it.
So coming back to your point about the workforce, and are we dumbing it down? You've just given great examples of where, if you offer employment to people across a range of settings, it's not dumbing anything down. Actually, it's creating employment. Winston Churchill said something like, you make a living by what you get and a life by what you give. And creating employment gives people an opportunity to put food on their own table, but also give something back. So you've just given a great example of why we all, coming back to the workforce strategy, should be employing more people with lived experience in our accountancy departments, our HR departments, our cleaning departments, and clinically.
When you think about it, the NHS is one of the biggest employers, really. And you know, you'd say to our trust, you know, a mental health trust, who does your cleaning contract?
Thank you.
And they always say, oh, it's shipped out. Yeah. You know, they don't think about what they can do in the patient journey and the care pathway. Yeah. Let's start with your pathway. We'll come back to some of this.
Okay, because I want to come back on the, is it a medical model, is it a clinical model, is it social, which is it? Is it dumbing down?
Which kind of model is it?
And
we'll come back to
and the answer is yes, it's all of
that.
All right,
watch my lips. We'll come back to that.
Good, I'd like to.
Don't be nasty to me. Oh, there's a latecomer coming in. It's Eve Richardson. Hi, Eve. Hi. You've already had a mention, Eve. You're too late now. Yeah, it's the late Miss Richardson. So where did it start for you? How did you get into this? You were in London, right?
I was born in Faversham, Kent.
Oh, yeah.
One of six number 5 child of 6, to very, very sort of humble working class parents who said, don't mind what you do in life, but be happy and treat other people well, and you won't go far wrong. I then spent many years not knowing.
Said that to me.
Yeah, look, it works sometimes, and
give her all the good gag.
Thank you. You teed me up. But I didn't know what I wanted to do, and I was between the ages of 18 and 23. I was a bit of a nightmare. I thought I'd like to go into drama. I wanted to travel. And then as I started to realise I needed to work to support myself, I thought, but I only want to work if I can help people, but I didn't know what that meant. I'd never heard of mental health nursing. I didn't know there was such thing as mental health nursing, and I think it was something like the nursing, a woman's magazine rather, or a London newspaper, where there was a big picture of 4 people, or just people, and something like, which one of these has got mental illness, and could you help that person? That led me to find out more about it. I went into nurse training at Free and Barnet Hospital in 1983, which is a big old Victorian asylum up in North London. And the rest, as they say, is history. I never looked back. I never regretted that move for one moment.
I'm always interested, because going into nursing, and it's the same with doctors as well, you go in with a very strong sense of vocation.
Yeah.
Because you really want to, you want to do that job. What happens to you when you say, actually, I'm not going to do that job anymore, I'm going to manage the people that do that job? What was your migration into management?
Yeah, that's a great question. I remember being in the School of Nursing and somebody coming in and giving us a talk on, you can do all of these things from nursing. You can be a practice educator, you can be a researcher, you can stay in clinical practice and become a clinical expert, you could go into management, so on and so forth. They asked for shows of hand about who thinks they have an interest in research, and they said, will anyone want to go into management? And I vividly remember going, I absolutely will never be doing that. Definitely not. I was outraged we were even asked, and here I am. So I suppose, never trust a word I say, because that was a definitely not. But I suppose I never saw the journey that way.
Well, what was it a Damascus Road, or is it just a migration?
It was just a migration, and so in each instance, I don't know, becoming a ward sister, it was and still is always because I've wanted to make a difference, and if I've seen a way I think I can make a difference that uses my skills and something I can feel passionate about, I'll do it.
So you're a ward sister.
Yeah.
And then what was your first management job?
Well, ward sister.
Yeah, and beyond that, what was
in
civilian?
So I think ward sister was my first management job. I had £1 million budget, 20 staff. I was responsible for safety, quality and standards. I needed to think about change and change management and how you do that. We were still in the institution then. Undoubtedly the toughest and most rewarding job in some ways, because the world's clear, my ward, my patients, my colleagues, my priorities, but equally you learn an awful lot about how do you bring people with you. Is it by just being nice? Is it by being passionate? Is it by being tough and slightly, And so I think that was my first management job, and I don't buy into a view in the NHS that there are a set of people over here who are managers and they have clipboards, calculators and axes, and there are a set of people over here and they have halos and they care about the patients. I actually think that clinicians or the delivery of great patient care, and you write about this. Look, I'm standing up because you said you have to be interesting in your latest management blog.
I was only having a laugh.
No, well, here I am. Oh no,
you shouldn't take anything I write seriously.
I've read the Lilley Bible, and but it just seems to me that there's nothing wrong with a well-managed, well-ordered, well-disciplined service.
I get that, but what I'm interested in ferreting out is there comes a point when you come off the ward, when you're no longer patient facing. When was your first non-patient? Can you remember?
I've never done a non-patient facing job.
No, because you're now going to play with words and say,
I'm not. No, I'm not.
But you know what I mean.
I do know what you mean,
well,
but I don't think I've.
We're going to talk about this all night unless you answer my question nicely.
I've never done a non.
I want to know what happens to someone. Is it you think you can do more?
Yeah. So I think, I'm not trying to play with words, but I don't think my job today is non-patient facing. I'll be on my wards, I'll be out nationally meeting with teams who are looking at how you improve care. I'll get to Hull, I've been all over the place and I will go there. And
she's coming, Hull. I promised.
Sorry.
I promised I'd get her up there. I've done it. Right.
But you know, in all seriousness, I think unless you're thinking always about.
No, I get all that, but I just, it's a long way from the ward to the board.
Yeah.
And you can make that distance as long as you like. It depends on how you run the organisation. And I just think that it just interests me what the
motivation.
Yeah. What happens at that point.
So I think I never wanted to be a manager. I didn't really want to be a chief executive. I didn't think I must be a national lead. I've never run my career that way. I think that opportunities come along and you think, I could do that. And I think I could do it well. And I think I could do it with a degree of support and with others. Why don't I? And if I've believed it can make a difference for patients or improve things, I've done it. So, after ward sister, I was a matron. So I covered multiple sites, and that was difficult. Suddenly not having the clarity of this is what I do, but having to work through others to deliver patient care, because as matrons you're not necessarily doing a great deal of that directly, you're working through others. That was probably my first job, of really having to work through others.
Yeah, that was a please you said that, because that's what I was trying to say.
Yeah, that was a crunch step.
Working through others.
And so that was a matron at the Royal Free Hospital, and working between the Royal Free and Friern, looking at the closure of Friern. I know you've closed hospital before, haven't you? You've done that.
We have the three of us in the room. We've got the scars to prove it.
Yes.
Yeah.
And and then before I knew it, I was head of nursing at the Royal Free for the mental health pond ward division, which was one of the 4 divisions at the Royal Free.
And mental health nursing was very different in those days, wasn't it?
Yeah.
In an institution.
Yeah.
There's a bit of me that sort of looks at very vulnerable people and says, you are very vulnerable, and in creating an environment where you're relaxed and calm. And funny, I was talking to Michael earlier about the meaning of the word asylum.
Yeah.
Because we think of asylum now as being, an asylum is like a lunatic asylum and all that, but actually the real essence of the word asylum, which is a port of call, a safe harbour. A part of me, when even Anne and I were working at Homewood, we inherited a place. I think it had its own farm, it had its own bakery, it had its own laundry.
We did.
You were like running a fiefdom almost, and you could understand why the thinking was like that, because they could do so very little other than try and keep people content, clean, well-fed and happy. And that's really, when I went up to Rob Webster's place, have you been there?
Yeah.
Okay, have you seen the museum?
The museum, yeah.
If ever you get a chance, he's very proud of his museum.
Fabulous.
I think it's the only museum like it in the country.
Yeah.
And it is amazing what we used to do in good faith in the name of mental health.
Yeah.
And
completely agree.
so when I look at places like Botley's Park, which was where I started, you could understand why they built Botley's Park. It was the wrong thing to do, but they didn't know it at the time. Yeah. And that was the really interesting thing. And one wonders, what are we doing today that in another 50 years we'll look back on and think, you did what?
Yeah. Anne is smiling because we were chatting just before the beginning of this event. We've had trust induction today, that's every month, and I always spend an hour with new staff on induction. Quite often I will give the example of having trained in an asylum 33 years ago, and one of the first things that was said to me there by a very eminent psychiatrist was, in a rather patronising way I have to say, almost, you little missy will hear a lot of stuff and nonsense about this hospital closing, it never will. And of course, as a ward sister, I was privileged to speak at the closing ceremony, which was great. It was nice, yeah. But actually, we mustn't look back too harshly and in judgment, because that was a product of its time. What we must do, I think, is know that in 30 years' time, people are going to look back at us and go, they did what? And that's why the 5-year forward view for mental health, and why it's irresistible opportunity to try and work with colleagues nationally to look at implementing some of what we want to do now.
I'll come on to that in a moment. Let's take you back. So you were a matron, you were trotting around sorting stuff
between the
out.
Royal Free and
Yeah,
Barnet, we were
okay.
closing it down, and it was all part of
which
that.
is much tougher than you think, and a lot of trusts got themselves into a real mess over it.
Yeah.
So then, what happened?
So then,
well, let me ask you. Can I ask you another question? Let's go into a really sensitive area, okay? And accept the question for what it is,
Yeah.
right? Because it interests me about the role of women in management. And you came into management at a time when there weren't that many women, and certainly not senior women in management. And I asked Sam Jones for the same question. But how did you juggle family with really a big job? How did that work?
well, so my first board level job was in the trust I'm at now. I've been in my trust for about 18 years now.
Yeah.
First as Chief Operating Officer and Chief Nurse.
You were there with Peter Carter.
And Peter Carter was the Chief
Yeah.
Exec.
I'll be with him at the cricket on
There
Friday.
you are. Well, Peter will verify this story. So my first board level position was with Peter Carter in a trust called BKCW, which was Brent, Kensington, Chelsea and Westminster NHS Trust. And I was keen to step up to board level as Director of Nursing and Ops, which I felt was a patient-facing job anyway.
Okay.
But at that point, my children were 3 years old and 1.5 years old.
How did you manage?
And my husband and I, truly, he's been phenomenal. We have shared all of this 50-50, definitely.
What does your husband do?
He works in, no, he's not in the trade. He works in transport. He plans how to get people to and from big stadia safely, so Wembley or the Emirates, or so he looks at all that modelling and how do you do that. So a completely different business. But
so you both got big jobs.
Both got big jobs.
Who looked after the kids?
Well, don't know, good question.
Social services are better than you think, you know. They just step in at the right time.
Yeah, they're great, on tap. No, but
I don't know how people do this. You
So-
know, you look at Sam Jones, right? She's got
Yeah.
a husband who
Twins.
who runs a hospital. She was
Yeah.
doing the Vanguard stuff, and she's got twins.
Yeah, and it was hard work. But for me, I went for the interview. I was nervous about stepping up to a board level post. And you know that bit in an interview where people say, "Have you got any questions for us?" I didn't have any
They
questions.
never mean it.
Well, and also you need to have asked your questions before then if you're going for a senior job, to be honest. Anyway, so I didn't have any questions,
It
but
means they've run out of questions for you.
but I had real sleepless nights before I went for the job, thinking I really want to do this, but I've got other responsibilities too, and I want to do both really well. I did want my cake and eat it. I've never seen the point of having cake you can't eat, really, as you can tell. You know, it's like, but I did want both, and I did want both. And so in that point, Peter, who was leading the panel, said, "Have you got any questions for us?" And I had thought about this, and I don't say it's right or wrong, it just made me feel better about that step and balancing responsibilities. So I said, "I haven't got any questions, but I want you to know something about me. I will work as long as you need me to. I'm utterly passionate about this, but I've got 2 small boys, and my husband looks after them in the mornings and takes them to nurseries, blah, blah, blah. And I can come in as early as you like. I won't mind being in at 5 in the morning. I don't, you know, I'm a worker. But I would really like in the evenings, as often as possible, to be there for tea time, bath time, story time, bedtime. And I know that if there's an emergency, that I have to have a plan B. If there's a board meeting, I have to have a plan B. I get all of that, but I just need you to know that I will flex myself this way, but I need some flex back the other way. And I want you to know that, because if that isn't what this trust needs at this time...
What did Peter say? Because I'll check on Friday.
It's absolutely true. Well, what then happened, obviously, was I got offered the job.
He said, "Sell your kids."
No, and
Sell your kids to Nike.
And I've tried. No, and he offered me the job, and something that, and I felt good that we'd had this honest discussion about what I wanted to make life balanced.
Do you think it was right that you felt you had to have that discussion, or do you think it's nobody's business?
I think it is. No, I'm of the view that it is your employer's business.
So how would you look at that now if someone was coming to you and you were on a panel and they were after a senior job, and you know they got a couple of kids, and have you got a creche, for example, at your hospital?
Well, it's not the nature of our trust, of course, because
everybody says that.
No, but we're so desperate. It's a creche. You know, where would you cite it?
Well, the best place you could. You got, you know,
what, Milton Keynes, Winchester,
Heathrow.
More than one creche. So we do. We tend to have partnerships with multiple other providers, but we don't have a creche because it's not who we are. But no, I think it's a good discussion to have, because in my case it was young children and I wanted to have a discussion that said these times will be important to me.
Supposing a guy had come to you for a job and had said, look, you know, my wife and I work, she has to get off and do the thing in the morning, and I'm going to look after the kids in the morning and get them off to play school or whatever, and look, I'll always be in here by 11 and I'll work till midnight if you want me, but hey, that's the way my life works, and I'll give you my best shot.
Yeah, well, do you know what? First of all, I would really admire the honesty and openness of that, because you'd be giving me the choice in a really honest way as your employer to decide whether I can flex to accommodate that. Secondly, it's not just children, is it? People have aged relatives, their spouses.
Well, increasingly, isn't it?
And they have others. And so coming back,
I just took a year off and looked after it.
And you know, and that was, well, I don't know about luxury. I mean, because that's a wonderful thing to have done, but also practically speaking, I'm imagining you didn't have to pay your mortgage, or you weren't, you know, things could stack up for you.
Well, I was in a fortunate position of being able to do it, but I mean, it is increasingly now, isn't it, where women are predominantly. I always say this about the NHS: we employ more women than men, we look after more women than men, we've got more carers of women than men, and we must be one of the worst employers for women on the planet.
So coming back to the workforce strategy, do you know, by increasing retention by 1%, if I pledge as an employer to be 1% better, and we all did that nationally successfully, that's 6,000 staff we retain. So I think it's really important that your staff can say,
we become a better employer.
We become a better employer.
Where have I seen that written?
In my workforce strategy, or the workforce strategy, I should say. But Peter Carter, so this was the other bit that was really important. We then were a board in full swing in a new trust where everybody on the board was working really hard, as did I, probably definitely long hours, but I didn't mind because it was so interesting. But we'd be in a meeting and come about 5:30, if it was clear it would be going on, he'd say, Claire, do you need to go now? And I really appreciated that, because normally I'd go, do you know what? No, I can, it's fine, I can flex another bit of the way. Occasionally I would need to say, thanks, I really do need to, and I appreciate it. Equally, he knew he could ask me for anything that was reasonable that would help the trust or what we were trying to achieve, and I would flex the other way to make that happen.
Pretty far-sighted.
It was great, you know, and credit to him, and I try and take that as a lesson. And yeah, if I had a chat that said, I've got an elderly mum and I really want to look after her, and I'm doing that with other members of the family, and I'm not going to be totally inflexible, but it would suit me if you. I would just admire that.
When I was the chair at Homewood, who was it? It was Michelle White, wasn't it? Anne, yeah, she had a baby, didn't she? And she was worried about. She was our director of HR, I think that was right. Yeah, and she brought the baby to work, and she brought it to a board meeting. And while she gave her presentation, I sat holding the baby, you see, and the local press took a picture of me, and it was in the local papers, chairman left holding the baby. Okay, so then Peter left, of course. He moved on to the RCN, did a great job there, and that was your big opportunity.
Yeah.
What was it like on the first morning?
So becoming chief executive at CNWL, I'd been there 8 or 9 years by then, and I loved the organisation, warts and all, and I really didn't want anyone else to be the chief executive. So I have to say I probably more applied to be a chief executive because I didn't want anyone else to, than because I thought I must be a chief executive. I didn't think I must be a chief executive. I thought, but this is our organisation. Here's an opportunity. I'm going to apply for it because I'd like to with the team. Lucky enough to be appointed. It was a Ruth Carnell was on my panel actually, and
she doesn't take any prisoners.
She takes no prisoners, no, and so anyway, so I was appointed.
She sat in that chair when we interviewed in a pair of Prada shoes.
Always, Jimmy Choo or Prada.
That's all I can remember of that evening. It was
yeah,
the
I don't know
shoes.
why. Well, these are Clarks, probably. Sorry, it's the nurse in me. But so day one just felt absolutely natural and right. I'd grown up with this organisation. I think with hindsight, Peter had probably been exposing me more and more to greater leadership opportunities and challenges. So it was fine. But Ruth Carnell did say to me when she phoned to say you've got the job, she said, at some point in your first year as chief executive, however great it seems to be going, you'll hit the wall. Something will happen and you won't know what to do. And instead of not sleeping, fretting, digging yourself deeper in or whatever, phone me. And I got to the end of the first year and I thought, hey, I'm so good at this, because I didn't have a hit the wall moment, because I knew the organisation well. I worked with a great bunch of people, and about 14 or 15 months in, I hit the wall. And at 9:30 one Friday evening,
It's always a Friday evening, isn't it?
I thought we're going to be plastered all over the nationals at the weekend, and it's all my fault. And it was just a dreadful incident, and the press were really onto this, and I just thought, I don't really know how to handle this now. And I phoned Ruth at 9:30 that Friday evening, and she said, oh, I'm so glad it's you, Claire Murdoch, and not Claire somebody else from the PM's office, I think it was. She said, I thought it would be this other Claire, and I told her what had happened, and she was just fab. And I think, so that's another lesson that I suppose other leaders that I've worked with over time sort of gave me about, know that as a chief exec a time is likely to come where you will hit the wall.
It's a great sprawling organisation, isn't it, now that you run?
Yeah. It's a big trust.
It is. I mean, it's a big trust. I mean, nothing wrong with big trusts, but it's the big geography that would scare me. Yeah. I don't think you can run it. You just run behind it and give your fingers crossed. I mean, how do you know what the hell's going on?
I think I mean, Paul Mid-Staffs was a small trust, you know, on, was it 2 sites? Kind of my dream job, to be able to have a job where you can just walk the patch, know everybody's name, and so on and so forth. And of course that's not the nature of my organisation, so I don't think big or small is the right question, though it gets asked a lot.
Well, it's communication, isn't it?
I think it's about, well, so what's your model, and what's the role of the board, and how flat
is your structure? Have you got, in each individual place, have you got someone in charge?
Yeah.
Is it like a branch office with a branch manager?
Yeah, because
and where do they report to?
So we divide the trust. We have about 7,000 staff. We're about 450 million turnover in the organisation. So we have, and
which is actually not a lot, is it?
It's enough. Exactly. Yeah. They're a bigger trust than us.
Yeah. No, in the scheme of things, it's not. You know, when you think of because I suppose really mental health. I need to phrase this properly, and if I phrase it clumsily, forgive me, but mental health is kind of cheap, isn't it? You know, you haven't got the big scanner thing, or perhaps you have, or you haven't got huge pharmacy repertoire to call on, you don't have operating theatres, you know, the actual operating costs are lower.
It's people, estates, pharmacy, and we're a community trust as well as mental health.
Yeah.
But I think that the nature of the work we do actually is, coming back to an earlier point, is partnership based. So unless you're working well with primary care, the third sector, the local acute trust, if it's children, the local school, and so on and so forth, local playgroups.
I mean, you've got to
work locally.
You've got to have some really talented people to be able to do that.
Yeah.
I mean, if somebody comes up with a really good idea, can they just do it, or do you have to go through some rigmarole?
Yeah, so it's a discussion that our board has often. So what's the role of a board? and
set
how
the strategy and hold the executives to account.
Yeah, and pretty much it is that. So then how do you enable the organisation to work in a heavily devolved partnership way where clinicians and others feel able to act and get stuff done in the context of their local setting? I think sometimes we get that right, sometimes we don't. It's an issue the board looks at permanently, and you absolutely are dependent on a talented workforce, whether that's clinical, managerial or both. And I think both in my own trust but across the country there's some incredible talent in mental health, and you have to, if you're going to work across a big geography, you've got to value the partnerships, value your staff, trust your staff, got to have good ways of holding to account and knowing what's going on.
Devolved budgets.
So devolved budgets, devolved management structures, devolved decision-making mechanisms, and yes, increasingly year on year we get better at understanding what's performance, what's going well. I do walk the patch a lot, but you can't manage a trust like ours by walking the patch.
You'd be forever on the road, wouldn't you?
And I am, and in the national job too.
Well, I want to come on to that because, you know, as well as having this very awkward trust to run, and I don't mean this, you know, well, it is awkward. The geography is bloody awkward, and it's all over. I mean, God knows where you've got branches and doing stuff. I mean, you're down in Surrey, you're in my neck of Surrey, darling. You're actually working in Surrey. Good heavens!
And they've let us in.
Yes, I do see about that. But then you've got London, you've got a huge mix of demography, of background, wealth, legacy situation. I mean, it is a really awkward thing to run.
No, it isn't, actually. It's no more or less awkward than organisations that people are working in here.
Oh, come on, it's a hell of a lot easier to run a hospital, district general hospital, isn't it? You're all on one site, you can walk around it in an hour. It's much easier. I mean, I'm not saying it's easier, but it's easier than you got 230 sites.
Probably,
You've
and
got
across
more branches
multiple
than Sainsbury's.
Yeah, and across multiple boroughs. But again, it comes back to what we were saying earlier.
Are you too devolved? I mean, why are you running services in Surrey? Why can't the Royal Surrey run Surrey?
We've been in Surrey.
Frimley Park. I mean, they're wonderful at Frimley Park.
We've been in Surrey.
They do everything.
For the 18, we've just won their sexual health services off of Frimley, but we've.
Well, that went badly wrong, didn't it?
Well, it hasn't. It's gone very well.
Yeah, but it closed down before you got there.
But we've been in Surrey ever since I've been in the trust. We've had a 100-bedded rehabilitation unit there that's operated for decades, and we've been running that forever. So Surrey's not new to us. The services, the people, the staff are new to us. I take your point. I'm not trying to diminish the challenges of a big geography and a wide range of specialisms across community and mental health, but I come back to my point earlier, which is it forces you to think about how you devolve responsibility and accountability. It forces you to think about the talent in your workforce.
That was the point I'm coming to, because, you know, people talk about running with flat structures. Well, flat structures are okay if you can see if you've got an eye line on the horizon, if you can see your flat structure. But your landscape, because of the geography, is an undulating landscape, and it's difficult to keep your eye on what's happening, isn't it?
I don't think so.
How many layers are there between you and a ward sister?
Me and a ward sister, there'll be 5 layers between me and a ward sister.
Tom Peters says that's too many.
Yeah.
What does he know?
Well,
he's not trying to run your trust.
Yeah, he can. Yeah, he's welcome to. And I do wonder, could we do with a layer less or not? But
so it's Tom Peters.
So yeah. so you have somewhere like Mid-Staffs or some of the smaller units, and they've run into trouble because culture, how you listen to staff,
weren't they, by regional health authorities who wanted everyone to be an FT. I mean, they were bullied into their problems. We know what happened there. No comparison with your
but
lot.
Other organisations that might be smaller, not just acutes, but there are good and bad in both.
You know, I mean, your place is more like running Tesco's than it is running Harrods. isn't it? In the sense that Harrods is a big shop all in one place. Tesco's, they've got 3,750.
We're a chain, and not only are we a chain, but we're a chain that works heavily through, whether you want to call it STPs, which is a kind of shorthand for strengthened partnerships around a population, and how you, whether you restructure or not, STPs I think are all about really, do you know this population? Are you working well across primary care preventatively and into tertiary services? Are you removing barriers you can remove? I do think we're a bit obsessed with restructuring.
Well, they're just closing beds, aren't they? STP should stand for stop, think, please. Stop, think, please.
They're not just
we'll
closing
get them in a minute.
beds.
What made you think? There you are running this. There you are running this unbelievably complicated trust. Very well. What made you think that you suddenly got so much time in the day that you could become the queen of mental health on a national basis? How does that work? Part-time senior management, fitting it in. That'll never work.
Thank you.
Discuss.
Thank you for that. Well, coming back to your time of life points, both my sons are your time of life. No, your point about circumstance, both of my sons are now, one's been to uni, he's come back again now, but he's living a really
You'll never get rid of him.
It's lovely, I don't want to, it's a great pleasure, but he's living an independent life, and I don't feel like I've got to be.
Washing,
definitely not. So but that's great. Actually, I have to say, when my oldest son was little, he went to stay with my sister for a weekend, Auntie Alison, and she was always indulged my two boys hugely, and she was doing ironing with my oldest, and she said, he was about 5, and she said, does Mummy let you iron? And he said, oh, Mummy hasn't got an iron anyway. So I'm certainly I did have an iron. I still feel very wronged by that, but
it's in the box.
Probably. But the point is that I guess both my sons are at an age now where they can be independent.
Self-indulgent, wasn't it? That you thought you could do 2 huge jobs. So you could just buy a bigger desk.
So I was really happy, and still am at the moment, to work longer and harder because this is a passion for me. I've never been one of those people that has work
and has home. Where does your husband live these days?
Yeah, he's there. I get his people to talk, or my people to talk to his people. But he's enjoying his career as well.
His solitude.
And I think the basis of our really happy marriage is we're so glad when we do see each other. We have lots to talk about. But it was a point in my career, I suppose, where this opportunity was an irresistible opportunity, because I think the 5-year forward view for mental health is the clearest roadmap we've had about some of the evidence-based interventions and services that we need to bring into mental health nationally.
Well, it's shoving everything into the community, and fingers crossed, isn't it?
It is not doing that.
That's the way I read it.
You read it again, Roy.
Once is enough.
But in all seriousness, I think it's one of the best plans on the block.
Well, the reason I like it, you are right.
I think it's great.
I think Simon's very clever. The way he set the scene, there's a fluidity in it. And it's what we often talk about, the Academy of Fabulous Stuff. It's positive deviance. In any organisation, there's deviance from the norm. Negative deviance is when things go wrong. Positive deviance is when things go right. It's capturing the things that go right and making them. That's my concern with STPs. I mean, they're just becoming really Jurassic Park. They're reinvented 1980. You can see it coming because they're under such financial pressure. They're not good. I mean, I when I first saw them, I was really optimistic, and I thought, I get what's happening, because if you recall, I wrote the report on healthcare in London, and we said what was missing was a strategic hand, and the STPs could provide that, but they've been a big disappointment, I think, because they've been sidetracked with other things. Fundamentally, the Jim Reaper has come along and said you've got to save 99 pence in the pound.
Yeah. Well, look, the challenges are well known and well rehearsed, and we're, in terms of what all public sector services are facing right now.
Today,
and
the Sunday newspaper.
Well, like I say, I've been very busy today, so I haven't seen Chris's.
Well, he was in the Sunday. The Sunday was saying he was saying you need 200 or 300 million. It's nice to know that people in charge have got such a precise handle on what's going on. We got 200 or 300 flip a coin million, and we need some more beds. Yes. Well, that's great, isn't it? Really, what a useless report. Why don't they wake up and do something, worthwhile?
Well, I suppose I feel this about, say, the mental health programme, and I sort of alluded earlier to the sort of unremittingly negative press, and it's all, useless, or it's not working.
True? Can I just stop you there for a minute? I mean, I think there was a time when you go back to the Zito days. Do you remember?
Early 90s, Jonathan Zito.
The Jonathan Zito, he's, funny enough, I met his wife again last year. She's still very active. When you think of Marjorie Wallace, who started SANE, and we were constantly on and off the box with horrible human tragedies that have occurred because of people who have had florid episodes, and we kind of just bunged them into the community with fingers crossed. I think, I mean, dare I say it, fingers crossed, we have learned. If we said earlier, didn't we, in 50 years' time we'll look back and think, did they really do that? Well, actually now in 10 years' time we can look back and think we didn't handle that very well. But a lot of it's settled down now. You get a lot, fingers crossed and touch wood, you get a lot less adverse publicity, although of course there's been the Sparrowhawk.
That's in learning disability.
That was in learning disabilities. Connor, yes. And there have been a number of other. I mean, some of these learning disability homes have had catastrophically things go wrong with them. So I'm not trying to sweep anything under the carpet, but I just feel somehow or other we've got a bit more of a handle on some of these.
Yeah, well, I feel that.
Is that right?
So yeah, I feel that. So you ask why now, and why did I do the job? Well, A, because I think I just felt that I could now. B, I've got a terrific team in my trust, most of whom I've worked with for more than 10
You don't do learning disability,
10 years. We do provide learning disability services as well, but not nationally. I'm not leading on LD, but we do provide. So I've got a great team, and at NHS England what I've encountered is a brilliant mental health team at NHS England. Seriously bright people who are passionate about this agenda too. So that was another reason why now I think the 5-year forward view sets out the best roadmap for a long time for mental health.
But let's just major on the 5-year forward view for a moment. Okay, the 5-year forward view comes to an end as it's presently constructed in about 200 weeks' time.
2021.
Has it been pushed to 2021?
No, it was always.
Okay, all right.
2021.
Well, yeah, but it depends how you describe a year, isn't it? It's 19, 20, 2021.
First of April,
yeah, but it's still 2000, isn't it, really?
It will soon be here.
It's 200 weeks.
Let's agree.
So,
we better be busy.
Okay, so what are you doing today to make sure you've sorted it all out in 200 weeks' time?
Yeah, so I think it's a great question. I do just want to give the last reason I applied for the job now. Which,
sorry, go on. Yeah.
Just if I might.
Was the money?
Well, there were two others. One was I checked out with Simon that he really meant that he wants NHS England and he personally to drive better mental health services nationally as a priority. And certainly when he interviewed me at the end of the interview, I didn't have any questions for him, and I didn't need to talk about my babies because they're 6'4". But I did say, I need you to know this about me, Simon. I really mean mental health and wanting to do all I can to work with colleagues across the country to deliver 5-year forward view and some of the great stuff in there. And I'd like you to take a few days to think about whether he'd offered me the job, and I basically said I'd like you to think about whether I really am your woman, because I really mean this, and shall we speak later next week, after he'd offered me. And his response was great, because he went, and that's why we'd like to offer you the job, because I really mean it too. And so knowing
so there's this mutual loving.
No, well, mutual commitment to try and change something and make mental health a priority. And
you're doing a big push on learning disability as well, isn't he?
He is as well.
Cummins was leading on that.
He is as well.
Who it is now, yeah.
And Jane still is.
And Jane's going to do the Chief Nursing Officer leading on learning disabilities, and she's going to run London.
She is.
And be the tooth fairy.
Get Jane on here and ask her those questions.
Actually, we get her back.
Let me just say the last reason why I said yes.
How many reasons are there?
Well, but because they're all really important. So right across the country, Absolutely, and you're seeing this in your visits, because I love watching what you're doing on Twitter and social media, and the work you're doing as you visit. Right across the country, there has never been a greater appetite to think mental health and do mental health.
Well,
and
I hope that's right, because I tell you, I mean, people, you know, I'm not naive about when I visit, you know. I only go to places when I'm invited, and they only go because they know they're going to get a kick in if they deserve one.
Yeah.
And they only ever invite me, and I only ever see good stuff.
Yeah.
I did some work for the Prince's Trust years ago, and I met Prince Charles, and we had one of these Highgrove lunches, you know, and he said to me, he said, you know, he said, wherever I go, I only ever smell fresh paint. And it was like almost the despair that he could never connect with the real thing. And wherever I go, you know, I only ever smell fresh paint.
Yeah.
It's very hard to connect. I mean, I've been to some fabulous places, and I'm not knocking it at all, but it is very hard to know whether or not I'm seeing the norm, the average, or the best stuff.
Yeah.
And I don't know that.
And you probably see a mixture of all of that, you know, because that's life. But right across the country, people have really embraced 5-year forward view, not just in health, but in third sector and others. And people are doing.
All there is.
Well, but there's loads of it. It's the single biggest, but it's not a mental health programme. It's an early intervention in psychosis. It's an A&E and acute hospital psych liaison programme. It's a children and young people's eating disorder programme. It's the biggest talking therapy programme of anywhere in the world that the New York Times was writing about the other day.
I featured it.
Did you?
Yeah.
And they are.
Yeah.
And so when you
they
say
said we were doing it because it was cheap.
it is cost-effective intervention, and it's humane. You know, 80,000 people a month now are coming into talking therapies on the NHS.
What are the outcomes?
And
Have we got any measures?
And yeah, it's absolutely the outcomes are measured, and we have a recovery standard, which for the first time last year we met. And I think, being very English, we go, oh yeah, but, you know, it's just that. 80,000 people a month coming into treatment for common mental health problems on the NHS with evidence-based interventions, showing evidence of recovery. Now, I don't say they're the only talking therapies. I know there are others, and it won't treat everything. But that's incredible that we're doing that in this country, and the rest of the world is looking at us.
I know
Isn't that amazing?
You've been engaged on affairs of state today and have not read the newspapers, but there's a thing in the paper today where GPs are saying that 1 in 3 people that are turning up at the surgery for these job chitty things have got a mental health issue.
Yeah.
So where's it all come from?
Yeah.
Where is all this mental health demand? Are we medicalising people who are just worried, and you know that's what life is? Or I mean, are we sicker mentally than we've ever been? I mean, is there any research? Why have what's happened? There's an explosion in the demand for mental health services. I mean, I kind of get the elderly frail. I mean, that's been a demographic line that you can follow, and it's, you know, the fact that it's taken us all by surprise is just that we're just bloody poor at planning healthcare. But we shouldn't. But what's happened? Is it austerity that's done it? Is it lifestyle that's done it? What has happened to cause this explosion in demand? Yeah.
I mean, I think one of the biggest things that's happened is we talk about mental health more now, and we don't expect people to silently suffer in shame and with stigma in the way perhaps that did happen. So I do think one of the very positive drivers, and I think there are possibly some positive and some more worrying drivers, but I think some of the more positive is we're now saying it's fine to come forward if you need help. You know, the baby blues, what kind of phrase is that? Really, women struggling postpartum or in the first year post-birth, you know, sometimes with some tragic consequences, and yet we now know that there are a whole suite of evidence-based interventions that can really help women. So we're now, of course, bringing their needs into the light more and saying we can meet them. So some of it's stigma and services availability.
You know, just to argue the other point, you know, the other side of the story, just for the sake of argument, I mean, childbirth is the most natural thing in the world. If it all goes well.
It's fine for you. Yes.
Yeah, but now I've had a kidney stone. I know what real pain is.
Did you have to nurse it in the middle of the night for months on end with no sleep as well after you delivered it, right?
It was like the Kainari diamond. It's enormous, this thing, and they prized it out through my willy. I never thought I'd piddle again.
Oh, too much.
Well, there you are, you see.
Because you're speaking to a nurse. Yes.
But I mean, just to take that point for a moment and look at it seriously for a moment. Childbirth is, like any vertical, was natural.
Yeah,
that we used to have families where mum would support daughter. Is it the breakup of the family really, or a restructuring of families that leaves women with children alone, and the extent to which the state involves itself now in looking after people. I mean, if you think about some of these kids, they get up in the morning, they go to breakfast club at school. They have school dinners. They're looked after at school. They have homework clubs. They go to school on Saturday mornings. The state is bringing our kids up.
Yeah.
I'm not saying it's right. I'm not saying it's wrong. I mean, I think actually Sure Start was an extremely good idea, and I'm sorry it went. But it is worth remarking on the extent to which the state involves itself in all our lives, and the extent to which we medicalise things.
Yeah. So, I mean, a great question, but the 5-year forward view, for example, and the priorities we're driving there is absolutely predicated on real need, we don't really talk about mental illness so much anymore. We personally think we should, because in fact I think we should reclaim that territory. They're talking about those mums with new babies. We're talking about mums who become seriously mentally ill, who commit infanticide, whose relationships break down, who are in true despair, who are psychotic. We're not. We've absolutely, in the 5-year forward view, not talking about drumming up business.
No, I'm not saying.
We're talking about meeting real needs.
Where you can intervene before that. I mean, you were talking about interventions earlier, public health interventions, aren't they? Really? Blonde, where did we go? And we joined in with that young mums club, and I had great fun in the ball thing.
I can't remember. That's terrible. Was it in Leicester? Lincoln.
Yeah, they had a young mums club, and everybody went to it. It wasn't a mental health focus at all.
Yeah.
But they were really. There was a kind of surrogacy, really. They were the peer support.
Thank you.
And it was there were older senior people there that helped with bringing up kids and the problems they have and all of that. I had a great time. I actually held a child.
Yeah, I think you got puked on.
Did the child have a great time? But no, in all seriousness,
no, they were good though. But those kind of things are the upstream interventions.
And the mental health task force, so just to remind that you've got a very knowledgeable audience, so I'm not going to sort of take you through the ABC of how we got the 5-year forward view, but the mental health task force led by Paul Farmer, it was an independent task force which Simon had the foresight to commission, took a year to look at, and he left them alone to do it, and he absolutely then embraced their recommendations, and we are where we are here. But they reported in February 2015, they made 58 recommendations about the state of the nation's mental health. Half of them were for the NHS, and the half that were for the NHS were very much about clinical evidence, evidence-based interventions, the things that can work, and treating people who are in real trauma and distress. But the other half were for wider society, and it's pivotal, because when we've done our interventions, when we've given first-class treatment, people go back to the rest of life. And I think we mustn't, as the NHS, and I don't think this is just true for mental health, I think we can't think that the NHS is the cure for all ills. People need good housing, proper education. They need community support. They need loneliness is the biggest killer of all.
That was the point I wanted to talk to you about, really, when we went and saw these mums with their kids. And I've seen it again. There's a thing called the Bennett Hill Project. I don't know if you've been there in Birmingham, and that's run by GPs, and that helps young mums look after their kids. You know, it's as simple as that.
Yeah.
It's the kind of thing that your own mum might have done, but
Yeah.
a lot of them are so young.
Yeah.
You know. And there's another one called the Craig Miller Project. I think it's still going in Edinburgh, which was much more embracing, but it was taking some pretty poor families really, and creating a community of their own where there was support. And you know, one wonders really how you see episodes of mental health coming.
Yeah.
You know, it's hard to spot, isn't it, until suddenly you're dealing with it.
Yeah,
Whereas,
can be.
you know, other symptoms, you know, often
Yeah.
manifest themselves more obviously, and you know sort of what you're going to be dealing with. You get the sort of catastrophic breakdown, and then it's almost too late. So it's the extent to which we as society are prepared to
completely
interfere in the
agree.
lives of ordinary people.
And to make contact with and reach out to ordinary people, which by the way is all of us and
Yeah,
people
but
with
that's
mental
what I meant.
illness as
No,
well,
no,
isn't it? And
I meant,
it's
I
about
meant
community.
ordinary in the context
Yeah.
of, you know, not having a symptom,
Yeah.
and not, you know, being poor, or not, you know, just
Yeah.
ordinary people like us. Where well, in fact, it's a phrase that Thomas McEwen used, who's a great public health doctor. In 1969, he talked about. He said governments have done everything they can in terms of public health, clean water, adult literacy and childhood immunisation. The rest, he said, is the extent to which government is prepared to interfere in the lives of ordinary people. And that's really what we're talking about now, isn't it? Interfering in the lives of ordinary people, but we see it in a different context.
Yeah, I suppose I hadn't thought about it as interfering in the lives
We can
of, but yes,
interfere
it
benignly,
could
can't we?
easily become so. I suppose that taking seriously things like housing, employment, support groups, opportunities for people to come together and support each other that's not medicalised and so on and so forth are crucial to building resilience and well-being. You know, so the NHS.
But then we medicalise people's lives.
But I don't see that, so I don't think it's the NHS's job per se to be doing all of those things. I think it is our job as a massively respected and well-regarded institution and much loved to be working with others and value more colleagues, you know, across a whole spectrum who are seeking to work with people in a different way. So I think we have to value that, and I think the STPs, the ones that are working really well, are you know that there will be variation, but I think the really good ones are starting to talk about who are our communities, what are the
44
assets.
of them, aren't there? And probably 10 of them are any good.
Ask me another question. I think that's too harsh, and I wouldn't agree with that. I wouldn't agree with that. There'll be people in this
25.
room. There'll be people in this room who are working
26.
with STPs and are really thinking about this preventative stuff, working differently.
Well, let me be clear. I'm not saying people who work in STPs are stupid. What I'm saying is people who work in STPs have got a dog's job, because we all know they're being driven to get some money rattling in the tin by 2020, and you know, all this business about innovation and change and all the rest of it. Yeah, sure, but you know, they can mess around with the flow dynamics of the system, but they've got to stop people coming into the system, and that's out with the reach of them or the timescale.
So some of the things that the 5-year forward view are doing, so last year we set up across the country, and by we I don't mean NHS England, we supported it, you know, but people across the country set up, for example, community eating disorder services for children and young people nationally. They've gone live just recently in the last 6-7 months. Some are still recruiting. That's amazing, because it's their community services designed to intervene earlier for children and young people who otherwise had very, very little until now. And you're right, we're then ending up in A&E, we're ending up in expensive tier 4 places, and not what they wanted. Or
How many tier 4 beds have we got?
About 1,400, give or take.
1,400. I never knew it was that many, and yet we still have trouble finding a tier 4 bed.
Yeah. We do, and there have been issues, but Simon committed back in March to open more tier 4 beds across country, and we're going to do that, and we're well down the track of opening more beds.
Where are we with children or young people in police cells? Because that's still happening, isn't it?
Very, very, very seldom, but there have been some cases where that is still happening. A handful of cases, it's never okay. It isn't all right. So we're opening these additional beds, and if we've got tier 4 providers here, we might open some in your area, mainly in the south and London. At any one time we do have vacant tier 4 beds. It's just sometimes the wrong kind of bed in the wrong place. So we know the capacity is there, and we're going to.
It's still. I remember in my day, you used to have to ring round. Are you still ringing round, or is there a computer?
There's a
screen?
better case management system than that, and a regional management system than that.
You ring round? You still ring round?
But there is. So because there's not, because
I'll take that as a yes.
Yeah, because we haven't got enough of the right kinds of bed in the right place. We can see from need and past demand. If we open an additional 150, primarily in the south and London, southwest, southeast and London, and we get these beds open quickly, and we're opening an awful lot of beds by March, and then the remainder in the coming year. That should stabilise demand. And then here's the thing.
How many beds?
We're going to open an additional 150 to 180.
Okay, how did you make that calculation?
Massive piece of mapping, looking at need, so basically looking at need. It was a needs-based assessment. And
how do you do that?
Well, the specialist commissioning team worked for several months with providers and others to look at where the demand was.
Is it like plot the historic growth and demand and add a bit on?
I think it's a bit more scientific than that, but there's
not much else you can do, is there? You can only look at the demography.
Yeah.
You look at the socio-economics.
So there was. They took various measures, and I didn't do the mapping, so I won't do it justice. But definitely they looked at incidents and what you would expect to be an acceptable rate of use for tier 4, given that you really want to avoid children and young people going to tier 4. They looked at historic use, and they looked at sort of geographic, and they weighted it all. So we think that if we open another 150 to 180 beds in the right places, and we won't close the beds where we've got excess.
I tell you what makes me nervous. Right, is when people say, well, we're going to have 150 to 180 beds. Well, there's 30 beds difference. And on a busy weekend, when you can't find a bed, that 30 makes a big difference.
One makes a big difference. It only takes one.
Why is it not a number?
Because, and I was going to come on to this, so we think it's between 150 and 180. At any one time we have about that many vacant beds nationally, but not always. So they're not just tier 4 beds. It might be a learning disability and mental health bed.
Being shipped to Scotland.
It might be an intensive care bed. It might be, there are different kinds of. It might be an eating disorder need that's needed.
So tier 4 offers a different level, a different type of service within tier 4.
Yes, you do.
Right.
It might be a low secure ward that's needed. It might be. So they've done a really detailed piece of mapping, looking at the kinds of beds that are needed and the demand. So we know it's not just 150 to 180 beds. We know the sorts of beds. But here is the thing, so it's all moving parts. We will open those additional beds, and we won't, whilst we're doing it, take down the surplus capacity. We've always got more than 100 vacant beds nationally, but I've addressed that earlier. So we will open those beds, but at the same time, of course, what we are doing is investing heavily in community eating disorder services with waiting and access time standards, which we are meeting. So urgent referrals for children and young people seen within a week in the community, and routine within 4 weeks. That's new, that's amazing.
And you're hitting those targets.
And we are hitting those.
The only person in the NHS that's hitting
we are on. Believe me, we delivered a lot of our targets in mental health last year, and that's not to say that there aren't pressures and there's not much to be done. It's why we've got a 5-year forward view, because there's much to be done. But at the same time as we're opening these beds, we are investing in CYP eating disorders, we're expanding the CAMS child and adolescent mental health services, and we've set up new care models where places like Tees, Esk and Weir have taken the tier 4 budgets and they are saying too many children go into these beds. If we can invest that in tier 3.5 crisis alternative respite care closer to home, we actually won't need as many beds. Okay. And so the reason it's 150 to 180 isn't some sort of vagary. If we need 180, we'll open them. It's because we're not waiting to open them and then investing crisis eating disorders.
Right, and of course when you get into a bed, you talk about beds, then you need someone to look after the people.
You do.
Right. Which brings us now to the thorny topic of 10,000 people. The Tinkerman's army is going to come marching over the hill and rescue us all.
200 or 300 people per STP nationally.
Yeah, but it's not that easy. If you break it
it's
down,
not easy. It's our biggest challenge.
It's a neat trick that I use myself, but it's totally disingenuous. I mean, you've got to find. It's only 200 in SDP land, right? Fine, but you've still got to find them.
Yes, you do.
We can't find enough nurses to do, inverted commas, ordinary nursing.
Yeah.
We can't find enough. You're talking about like eating disorders, looking after people with eating disorders in the community. Yeah. It is excruciatingly difficult to do that. Excruciatingly, because it's not about not eating disorders. It's about so much more. And the lives of these children, their own, often they're just children, aren't they? Have, and how they're growing up and how they're managing adolescence and their home life and all those things. I mean, it doesn't just take one case person to do it. I mean, you need an army of people to look after people in the community, and I just do not believe that we will get to 2020 or 2021, because you want to call it the year 2020 stroke 21.
31st of March 2021 in my book. Last time I looked at the calendar, Roy, that wasn't just spin. That was a real date.
That'll do. We're going to get there, and we say, do you know what? We didn't know who is going to recruit them. Is it Health Education England?
So the plan.
I mean, God help us if it is.
The plan is led by HE, but actually NHSI are doing great work with HE. NHS England, trusts and STPs will do it.
Okay.
So it is all our job.
How many interfaces have we got there?
Well, it's the same number as interfaces as we've got now.
Got plenty of room to pass the parcel around. Who's responsible? Who do we hold to account to recruit 10,000 people by the 31st of January 2021? Whose job's on the line?
Well, probably mine, maybe. I don't know. I'm the SRO for mental health, with responsibility across all of the arm's length bodies for the delivery of the 5-year forward
But you'll just say, well, look, Health Education England didn't do it.
Well, wouldn't it be nice if the world were simple enough to go, it's their job, end of? The truth is, and the painful truth of this one is, it is all our jobs. It's the job of the community manager or the clinical leader to treat staff better and make work more fun so that staff stay longer. It's the job of HE to have enough training places and to advertise them well enough and to support people in training together with the provider so that we don't lose so many through attrition in training, but keep them in training so that when they come out we've got good jobs for them. It's the job of trust to support people in the first year post-qualifying better so that we don't get quite such high turnover in year one of, say, newly qualified nurses. I'm afraid the simple truth of all of this is it is all our jobs. As a trust chief executive,
I must say that fills me with dread that there's no one in charge.
Well, there is. I suppose ultimately I'm the SRO for mental health, aren't I? Health education, well, I don't mind. If somebody's got to be prepared to say, I'll step forward. I'm just hoping when I do, so will thousands of other people with me who are passionate about this agenda. And I think they will. Let's talk about Health Education England. I mean, they were dealt a bad hand. There's no question about it. They were set up, had their budget slashed, and then they had the budget slashed again, and then they got buggered about with the bursary, and now everybody who's born this year has got to become a nurse, otherwise they won't hit their targets. I feel sorry for them, really, but it's a forlorn prospect, isn't it? They're not going to. They just won't. I mean, look at the training places. They've got to be funded. How's it going to be paid for? You can't. 10,000 more people in the workplace earning, say, £23,000 a year, right? Yeah. 10,000 times £23,000 a year. We don't have the money. We can't pay the nurses we've got now. We do, and we can. it's not easy, but we
Well,
are
where would the money come
investing.
from?
We are investing more in mental health. We have seen growth in
It's
expenditure.
only because the money's come from somewhere else. It's not new money.
Well, everything you spend comes from somewhere else. If you know, I don't know what that means really.
Well, what I'm saying is that
This is money for mental
the
health.
NHS has had flatline funding for 7 years. Okay.
Mhm.
75% of hospitals are in debt, in trouble,
Yeah.
and most of them have got more
It's
debt.
really tough.
They've
Tough
got
times.
more debt than they can pay back.
Yeah.
The Treasury will have to write it off through public dividend capital or something. I mean, they'll have to do some jiggery pokery because the hospitals will never save enough money to write it off.
Yeah.
So, although it is globally, a global health budget, what we're trying to invest in mental health, and I'm not saying we shouldn't do it, I just don't understand the finances of it because it's a shed load of money.
We will be investing that money, I think, in the 14, 15, 15, 16. Believe it or not, it's absolutely true, and people don't say, well, it can't be, but we've spent 1.4 billion additionally in mental health from 3 years ago. That funding's going up. Fact. You know, what's paid for the new perinatal services, the expanded CAMS. Last year, CAMS services in this country saw 21,000 more children and young people. The 80,000 people a month that are coming new into fully funded IAP services. You know, we're paying staff, investments coming in. Is it enough? Would we like more? These are big questions. Absolutely, I get that. But money is coming into mental health, and I'm not making any apology, though I feel sort of sympathy for other parts of the system who may be struggling. I make no apology for the fact we're now spending it on mental health.
There's no reason why we shouldn't. Right now, I'm sorry to cut you off, but it's 20 past and we've got to finish at 1:30 because I've got to get back to the day centre. The curfew at the old people's home. Should we do some questions? Have we got any questions, Blum? I'll come to you in a second.
Yeah, we've got some great questions on here. First of all, Claire, lots of people saying absolutely masterclass in handling Lilley. Loved it.
Oops.
What else get a slagging, Michael?
Because you deserve it.
Well, a few comments about they wish Roy would have let you finish some of your sentences.
Oh.
I think you made very strong points.
The John Humphreys of...
Yeah.
Can't let you witter on all night. So.
But your positivity, you people are saying about your positivity and your commitment and passion about this. How do you sustain that?
Two things really quickly. One, I was born glass half full, and I do thank my mum and dad for that, because it's nothing I did. I just think there is so much genuinely in what we're doing now that we should celebrate a bit more. I think we run some of the best mental health services of anywhere in the world. And others say that, absolutely. Others will say that. And the Nuffield Centre's going to make a report quite soon that's going to claim that.
What was that report the other day about? We got some of the worst. What was that one?
Be quiet, Hart.
Anyway, it's my belief and the belief of many others who would be independent and external that we do. So I think there's a lot.
Do you feel your time has come as a person, nurse, manager? Do you feel this is your time?
I've always felt my time has come.
But with
every
the
job
5
I've
year
ever
forward
done.
view, the money, it's kind of it's coming into the
more people.
The plans coming together.
It is, and it's a shame it's coming together when the country's in recession and a lot is tough. But I think the plan is hugely coming together in lots of ways, and that's not to deny the pressures or the tough stuff. I just don't. But my positivity comes from I see all that is good that we're doing. I'm realistic about the pressures. And B, oh my God, the people you work with in mental health are amazing. Amazing, whether that's service users, their carers, the staff who are so committed to better mental health care, a lot of the leaders who are thinking about how to innovate next. There are amazing people right across the country.
You go into some of these units that the public never see. Where people who are seriously unwell are looked after in the most courageous and sympathetic way. It's very moving, I think, sometimes to get to have the opportunity to see that. Right, lady in the nice blue cornflower blue jacket.
It was heartwarming and inspiring.
Thank you.
And my question is what's your thinking about how mental health services might be provided in systems of accountable care?
Yeah, so there's lots of talk at the moment about how do you provide better healthcare in sort of more integrated systems. I have never believed that the answer is just give it all to one organisation, and if only one organisation ran everything, it would be easy.
It's called a district health authority.
Well, you know, yeah.
I used to run one.
Exactly. But I do think getting much more clearly sighted on pathways of care and designing them together a lot more jointly in partnership does bring better outcomes, because if you've got a great site liaison service in an acute hospital, say, you need to be designing that and delivering that with the GPs in mind, well, always with the patient and service user in mind, but with the acute trust clinicians in mind, with the GPs in mind, with the community mental health teams in mind. And for me, accountable care systems are, to be honest, what we've been trying to do for years, which is see across a pathway, think more preventatively. So I think mental health has a vital role to play. We're doing more
I'm going to speed you up because we've only got 4 minutes left, and I've got a couple of questions. I'll come to you in a second. I mean, accountable care organisations, I think we need to look at them through a different lens, I think, because accountable care organisations come with a capitated population-based budget, and that means you can only spend that £1 once, and so you've got to decide across the whole system where you best spend that pound. And although, you know, I look back on the days of district health authorities that I was involved in, and they were accountable care organisations, and it was a disaster because we could never get a handle on the money. But it was before Bill Gates invented spreadsheets and before mobile phones and before almost everything else. It was impossible to do. Now it's a lot easier to manage and run and know what you're doing. So I'm optimistic. So, you know, when a youngster comes in who's slashed her wrists and she's found in the street and somebody rings 3-9s, what do? We stitch them up and say, oh, you need to see this psychiatric liaison person, they'll be in on Wednesday, and you know, all of that will change, or could change, and it is changing, because are there psychiatric liaison staff in all A&Es now?
So by 2021 there will be psych liaison services in all acute trusts, and half of them by 2021 will be operating to what's called full core 24 standards. That's 24/7, using a good evidence base and looking at a certain skill mix and level of staffing.
Because we've not mentioned dementia at all, have we, really, tonight?
Look at that.
Which is
amazing.
A discussion of a whole different type. I mean, and if you think 800,000 people have dementia now, it's going to be, what, 1 million by 2025? A disease we have no idea of really what we're going to do with it, and we just have no idea what to do with the people. And some of the services are horrendous. You know, the care home standards are so poor in many cases. Right, yes, Matt, far away.
Back on your issue of retention, what is your vision for the mental health of the workforce, both within mental health, but also almost as a, let's say, petri dish for the wider NHS?
Yeah, I think it's a great one, because we should be one of the best employers and take the best care of staff's mental health. I mean, that's such a long answer there, because I think what makes for good mental health in the workforce is everything from having a doable job, working in a good team, you know, so that your caseloads don't drown you or stress isn't overwhelming you, having a good team, back to the flexible working point earlier of acknowledging people have lives.
Getting home, bathing their babies.
All of that, but plus also some really good in-house systems of counselling support, being more honest and open about. And on induction this morning I was reminding staff that 1 in 4 of us will experience a common mental health problem. Important to put your hand up early, get help sooner. Makes great economic sense to keep you at work, so why don't we look after you better, because you might need to take a few days off and get sorted, or be released regularly for a course of counselling, but if it's keeping you at work and contributing, then brilliant. And I think this is where mental health will also play a huge part in accountable care organisations, because as we get more savvy about this, we will realise that taking better care of people's psychological health and well-being will lead to physically better people and cheaper care.
Depression in old age.
Oh, we think that growing old, somehow, I think there's a, somehow, growing old and having long-term physical health care conditions, well, of course she's depressed, her friends have, died, or she's got arthritis. So the people who respond best to talking therapies, and this is a big challenge for our IAP services in the coming year, are older people. Evidence-based interventions for older people, talking therapies, can make a huge difference, and guess what? They then cope with their complex comorbidities. You get them thinking about tackling loneliness. They'll take their medications more, they'll perhaps walk a bit more. So the role of mental health and the 5-year forward view in accountable care and intervening differently in older people, as you say, is colossal. It's cost effective, it's humane, and the time has come. We've all got to get with it.
We've got to get with it, and we're absolutely right up the buffers of time. Have you had a good evening?
I hope so.
Not you. No. No. Okay. Claire, you've been a really interesting guest, and thank you so much for giving up your time. Now we have a little gift that we always give our guests. It's here it is. John's got it for you here. It's a bottle of whiskey. Most inappropriate probably, but never mind. And it's the important thing about it is the important thing about it is it's Welsh whiskey, right? Which is the best whiskey in the world.
Is it
sorry
really?
For any, absolutely is. Forget what the Scots say.
You do know my surname's Murdoch,
Yes.
and my dad was a wee Scots.
Yeah.
He now wants me to donk you.
It's the best whiskey in the world. Try it, and you'll see what I mean. And the other interesting thing is that it is quite an expensive whiskey, and it's just above the threshold where you have to declare it.
You're not going to believe this, but it's reduced in Waitrose.
Oh no! Well, ladies and gentlemen, soon to be Dame Claire Murdoch.
Yeah. Thank you. No, thank you. Thank you very much. Thank you. Thank you.
Okay, goodbye everybody. We got. Are we still live? Yeah. Okay, thank you all very much for watching. I hope you had a great evening. We sure did here. We will announce when is the next health chat. That's the
TBA, but then we've got Ed Smith in November.
Yes, Ed Smith is coming back. The chairman of NHSI is coming back to do a retrospective for us. So don't miss that. That would be really interesting, because I find that once people are out of job, they tell you so much more about the job. So we come to that one. I think you would. Yeah.
I will do that.
And please don't forget your pledges for Fab Change Day. Weeks, Fab Change Week. God, I got the sack twice tonight. And it's between the 13th and the 17th of November, which I do know about. But it will be on us. It's less than 80 weeks, I think, now away, and 80 days away. And
sacked again.
And that's it. Shit, I've had enough. Good night. Claire.